Hi, this is Nael Bahor, and I'm Megan Williams. We are two senior emergency medicine residents at the University of Toledo Emergency Medicine Residency Program. Today we're going to be talking to you about end-tidal CO2 monitoring. We've pulled together from a couple different resources and come up with a pretty cool protocol for use of capnography in the pre-hospital setting. We would also like to give thanks and shout out to the Department of Public Health at the University of Toledo Medical Center for allowing us to use their resources and be able to film this video today. Goals and objectives of this video and our protocol. We're going to tell you exactly what end-tidal CO2 is and what the current uses are for this capnography. We're also going to review the clinical indications for end-tidal CO2 monitoring, and we're going to tell you a little bit about the step-by-step procedure on how to properly execute capnography, although there will be a subsequent video that will show you a visual step-by-step on how this can be done. Lastly, we're going to review some abnormal tracings, go over some equipment and tubing things involved with capnography, and also giving you a little tips on the troubleshooting of what happens when capnography goes wrong. What is end-tidal CO2 monitoring? So end-tidal CO2 is the measurement of carbon dioxide in each exhaled breath. You can see this a number of different ways, either numerically, which will give you the total amount of the CO2 that's being exhaled, or you can see it visually, which is a real-time graphic display, also known as the waveform capnography, which is what we typically use in the hospital and pre-hospital setting. This can be seen at the bottom of the screen. Those waveforms that are filled in, those are the real-time displays of end-tidal CO2. There's a couple of different trends we need to talk about that make up this curve. End-tidal CO2, it will increase during exhalation. So if you look at the red square, you'll see that it increases during exhalation, and it will decrease during inhalation, which is the blue rectangle seen on this graph. This will create the waveform, kind of the seesaw, a waveform pattern that you see on the screen. And if you look at the yellow star, that's the end-tidal CO2 value, and it's going to be the value that's most important to you. There's a couple different uses of end-tidal CO2 monitoring. The most important ones that we typically use it for are the post-intubation period. You can verify that the tube is in the right position, and if the tube is not in the right position, it gives you kind of a jump at things so you can put it back into the right position. We also use it during CPR. You can monitor how effective your compressions are, make sure the depth and the rates and everything are very adequate for resuscitation. The end-tidal CO2 monitoring also provides real-time information on three different things. First being ventilation, so how effective are the lungs at removing the carbon dioxide? It will show you perfusion as well, how well is carbon dioxide being exchanged through your vascular system, and metabolism, are your cells producing enough carbon dioxide to survive?
Thank you, Megan. A few words on clinical indications. First thing important to remember is that the device must be used in patients with advanced airways placed in the field or prior to transplantation, as well as please remember that stabilizing the patient is the most important thing. Implementation of capnography is secondary after the patient is stabilized. A few other uses. It allows you to make sure that your device is placed properly. It also allows you to monitor the condition of the patient, and as well as the use of your EP tube during transportation. And mentioned a little bit ago, during CPR, ensures that you are providing good and effective CPR. As well as while performing CPR, it will tell you if you've reached the point of return to spontaneous circulation and that the patient is perfusing better now, as well as that the ventilations you are providing are adequate and appropriate.
And what absolute contraindications are there to using capnography, Nael?
There are no contraindications.
That's right. There are no contraindications to using capnography. So when you can, use capnography. It can definitely be your friend in these pre-hospital situations. Again, no contraindications. So for the procedure, we do have a step-by-step procedural video that will follow this video that you'll be able to watch exactly how things are set up and what to do during this whole procedure. So if you want to see how things are done, you can watch that second video following this one.
Things to consider, a few tips here of using the capnography. Number one, please remember that as soon as you connect it, the value that you see is real time and it is appropriate. There is no need to make any adjustments or to mess with any settings.
Some normal values that we need to go over. So normal levels of end-tidal CO2, you want to be between that 35 and 45 range. So a normal functioning person like you or I, Nael, if you had hooked up capnography to one of us while we're breathing, we would hope to be in that normal range. So normal cardiac and pulmonary function, that's what you want to see. You can also check to make sure that your ET tube is in the correct position, or any supraglottic devices, LMAs, King, airways, things like that. You want that nice normal level of end-tidal CO2 to make sure that those are in the proper position. It can also be an indicator of ROSC, which is the return of spontaneous circulation. So during the resuscitation period, if you have a sudden rise to normal CO2 levels greater than 30, then you want to think that the patient is now making a comeback.
A few words here on abnormal values. A value of 70 millimeters of mercury would indicate severe hypoventilation. A value of 5 would make you think that you are either hyperventilating the patient or that the airway is not placed properly, as well as if the apnea alarm goes off, you know that the patient has not taken any rest for 30 seconds and an adjustment must be done.
So if you're monitoring end-tidal CO2 and you see that there is none detected, then you have to think a couple of different things. Number one, that there is a loss of airway function. So the patient is no longer breathing, the tube is no longer in the correct position. If it's in the esophagus, you're not going to get any CO2 return. So you've got to think about repositioning the airway. Loss of circulatory function, anything such as a cardiac arrest, a massive hemorrhage, or a big PE can cause you to suddenly lose circulation, and you're going to not be producing any CO2. So you got to think about things like that. And lastly, equipment malfunction. Is there an obstruction? Did the tube become dislodged? Anything like that. So if there's no CO2, you got to think one of these things and act appropriately.
Another few pointers. Please remember that the tubing used is for single use only and must be discarded afterwards, as well as capnography is safe for both adults and children and can be used with both without any difficulty.
And are there any contraindications to that? There are none. Kids and adults, both safe.
This is simply a picture showing different types of devices that will measure CO2, and you can see that there's the numerical and the visual picture of the waveform, and there is a picture of what the tubing looks like.
This is a picture of normal tracing. We talked before about the normal values being between 35 and 45, and if you look down at the bottom where the yellow CO2 marker is, you can see those waveforms are nice and normal. The increase and decrease are all in the nice normal range of 35 to 45. So that's what you want to see when you hook up the end-tidal CO2.
Alrighty, the next few pictures are going to be showing us some waveforms, and these are considered abnormal, and each of them should indicate to the provider that a problem is going on and will allow us to rapidly recognize the issue and correct it. This first one here shows two good waveforms and then a sudden loss of the traditional waveform. This could demonstrate that the ET tube has been disconnected, dislodged, kinked, or obstructed, as well as even some sort of loss of circulation that needs to be addressed right away.
This is a waveform that's showing one nice normal waveform and then decreasing end-tidal CO2. So if this happens, you want to think that there's maybe a leak somewhere. Is there a leak in the ET tube cuff? Is the ET tube in the right position, or is it in the esophagus? If it's in the esophagus, you can get one or two normal readings, and then you'll have a sudden decreasing value because you're not having the normal CO2 return. You also have to think about a partial obstruction of the tube. Nothing that's causing a complete obstruction, so there still is some CO2 coming through, just not as much as you would expect for normal values.
This one here shows what you would expect in CPR, with showing at least 10 millimeters of mercury values here. This would indicate that you are at least performing CPR correctly.
This would be the return of spontaneous circulation that we talked about before. So you have your CPR values of 10. You see that your compressions are are nice and effective, and then all of a sudden you have a spike in your end-tidal CO2 and it comes way above 30 into the normal range. That's the moment that you know that your patient their circulation has returned. So then you would want to go about the checking for pulses and making sure that you follow the appropriate protocols from there.
Here we have Megan's favorite waveform, the shark fin. This simply demonstrates that the patient is retaining more CO2 than they should, and this is common in conditions such as an asthma exacerbation or COPD.
This tracing looks like it's a normal tracing. It's just very slowed, very prolonged. This would be your hypoventilation tracing. So if you notice that, yes, you have the 35 to 45 normal levels of CO2, everything just looks very prolonged. This means the patient's just not taking enough breaths. So if you're bagging the patient, maybe speed it up a little bit. That's all that this is showing.
This would be the opposite. The patient is either hyperventilating on their own due to impending respiratory problems, or that the person bagging the patient is overdoing it and they need to back down.
This is a decreased end-tidal CO2 tracing. It's different from the decreasing one. This is when you hook up the end-tidal CO2 and you see that there's not a normal value. It's way below your value of 30. For these situations, you want to think about apnea. So your patient is not breathing. That's a bad thing. You need to act quickly. You can also see it in procedural sedations, which would be used more in the hospital setting and not the pre-hospital setting. But this can be a sign that your patient is going to have some impending respiratory malfunctions, and you should probably take action pretty quickly.
This is our final slide, and it simply is for reference at a later date for troubleshooting. If you find that your device is not functioning properly, you can refer to this document here to see what steps you need to take to ensure that it is properly working.
Okay, in conclusion, that is all we have. Hopefully everyone is a capnography master at this point. Just recapping some of the most important points of our presentation. Capnography has many uses for hospital and pre-hospital settings. Several important ones we need to think about: confirming airway position, making sure your ET tube or your supraglottic airway is in the right position. That's the number one thing that's good for your patient. It will also assess the adequacy of CPR and ventilation during the resuscitation period, also very important for your patients. It's very easy to set up and interpret the information instantaneously. You can watch the procedural video that follows this one, and you'll be able to see that, yes, indeed, it is very easy, very user-friendly. And lastly, it provides vital information early on in the assessment period, and it allows for life-saving intervention to be initiated more quickly in the resuscitation period, hopefully giving the patient a better outcome in the end. So that's all we have. Nael?
Nothing. Thank you guys for allowing us to talk with you today.
And thank you to the Department of Public Health once again at the University of Toledo Medical Center. Thank you.